Good afternoon. I am very delighted of showing you today the first clinical implementation of an endoscopic assisted percutaneous radiofrequency cordotomy. The aim of this study is to show the intradural visualization of the cervical spinal cord in cordotomy due for untreatable pain syndromes. So we treated 20 patients with nociceptive type cancer out of malignant cancer who had no success in other treatment options like even putting an opioid infusion pump. The aim of the cordotomy is to interrupt the pain contralateral fibers of the spinothalamic tract. The spinothalamic tract, which resides in the anterolateral column of the white matter of the spinal cord. Currently, this procedure is developed under X-ray guidance. This means fluoroscopy or CT, but we would like to introduce this technique using the endoscope. So basically, the procedure is a patient who is in a supine position, and we will perform the procedure in the lateral aspect of the spinal cervical cord, and the landmark will be 1 centimeter below the tip of the mastoid. The endoscopic view will allow us to have direct visualization and use direct landmarks. These landmarks will allow to make a procedure faster, easier, avoiding the shorter the time for fluoroscopy and avoiding the use of contrast medium. So at first, we go into the interspace C1, C2. We introduce the endoscope, which is an endoscope of 9.9 millimeters. And then we start to have the visualization of the structures, the arachnoid membranes and the ventral rootlets. We can see also the PR surface of the spinal cord and the ventral, the radical blood, the blood vessels of the spinal cord and the root entry zone for ventral and also dorsal root entry zones. So with these landmarks, we are avoiding the chief of making mistakes for the spinal cord. So here is ventral, here is dorsal. This is a left approach, and here we have the dentator ligament and the ventral root. The intermediate point between these two will be our target. At first, we introduce the electrode, and once we introduce the electrode, at the beginning we make electrical stimulation. This electrical stimulation should produce sensory alterations, but not motor alterations. If you are producing motor alterations, it means you are too posterior, and it means you are in the corticospinal tract. This means contractions of the neck or the upper limb. And then we do a radiofrequency lesion. This radiofrequency lesion is performed 60 seconds, approaching 75 degrees. It's a thermocoagulation lesion. So we have performed for this study 20 patients with malignant type cancer who did not respond to other options like even opioid infusion pumps. This study was performed in Hospital das Clínicas in Sao Paulo, where there is a long experience, more than 1,000 cordotomies performed with the other fluoroscopy technique. So we already know, and either for the literature, that the patients that got better are the unilateral patient, the patient who had unilateral pain, thoracic pain, or limb pain due to malignant cancer. So we rather to perform in the unilateral patients. Sometimes we perform bilateral patients. We did it for a medial line pain. So in total, we performed 22 cordotomies. The result, the scale that we use for the result is excellent when the patient in the procedure is pain-free. right after the procedure, and this was 75% of the patients. Good when the patient still have some pain, but if comfortable, and fair when there is no change. For our complications, we have a mild motor deficit in lower limb, but with physiotherapy, it recovers over a period of 14 days. In the literature is also some loss of urinary control and respiratory problems reported, but with these special landmarks that the endoscopy gives you, you are safer not to have these complications. This is the follow-up. Just we can see how the lesion appears in this T1 image, and we are able also to perform spinal cord tractography to see where is the lesion. So our conclusion is that the endoscopy-guided cordotomy is a safe, precise, and effective surgical treatment for intractable cancer pain, that the direct visualization of anatomical landmarks makes target determination fast, safe, and the use of fluoroscopy short. You will only use it to identify your space C1, C2, and you don't need contrast medium administration, which sometimes can cause some problems intrathecal. We would like to encourage spine surgeons to use this approach, and it's open now also to do this kind of intradural percutaneous procedures, even to do biopsies or to introduce this kind of a small endoscope of 0.8, 0.9 millimeters in the sacral roots, or do to biopsies of tumors. Thank you so much.